Well, thank you, Dr. Muzaffar. It was an excellent talk on bifurcating lesions. So the next talk would be on left main PCI. We all know that left main has always been a surgeon's job. But because of the improvement in our tools, in our skills, and in techniques, it has become pretty much shifted towards interventionist, although it still is a 2A as part of the guidelines. So our next talk is going to be presented by nobody else, I think well known. He doesn't need any recognition. General Sohail Aziz, he would tell us the tips and tricks of dealing with left main intervention. Hi, sir. I would request Dr. Rehan to come and be panel of experts.
Assalamu alaikum. It's great to be here, and it's lovely to see friends and old faces here. It's a fellows course, so there's a lot of data involved in all of this, but it becomes a little boring. So I've tried to keep it going. So Bismillahirrahmanirrahim, and it takes a little while for the slides to change, I think. They have connected me through the Zoom. Yeah, so greetings from 4G Foundation and Kulsum Hospital. There's no conflict to this. So we've had so much fears and phobias going around about COVID and bird flu and AIDS and so on and so forth. But in the end, it all boils down to coronary heart disease, the #1 killer. And that is the real big effect which has on the economy and lives of people. This is just one of the cases we had. It's a 3-vessel left main stem. Eventually all these will start to play. And so the right is totally blocked. There's a left main, then there's an ostial LED, and then there's a long circumflex, which is also very critical. And you will see a critical lesion in the circ also, which is not visible, but you can see it in this view. And so that's the epicranial showing the bifurcating LED with the ostial left main. And the circ is there too. And after the intervention, we did the right first, did a double stick and fixed that. And then we did the left main bifurcating. It was DK crush. I think one of the AV circs gone missing, but it started to reappear. So that is, I think so, what Antonio Colombo said about 10 years ago, that no anatomy, no patient, there's no limit. You can do PCI on any of these procedures. So by and large, it's seen in 5% of patients who undergo angioplasty. The risk factor basically is male, gender, and age. And isolated left mains are seen in 5% and seen more frequently in women. So basically, we have the ostium, the mid portion of the shaft, and the distal portion being the bifurcating portion. The average length is 10 to 15, but it can be sometimes so short. And the shorter it is, more difficult it becomes to treat. And the diameter is from 3 to 6, and sometimes the ostium becomes flayed out so much that you won't have a stent to cover it. So to me, sometimes the limitation of intervention is the size of the left main, whether you can cover it with the stent or not. And the other thing is that anything which is 50% in left main requires an intervention. But what exactly is 50%? It varies from eyeball to eyeball, and lots of time there's a big issue about it, especially for the surgeon, because if the lesion is not critical, the Lima graft will not develop. So they are very choosy about making sure that it's critical. So saying 50% and it does behave 50%, that's different, and there are different ways of doing it. Surgeons, for some reason, always rely on CT scan, MSCT, whereas we believe in FR and IVUS and MPI, and some people look at stress echo to see if there's ischemic in that area. So this is an insurance graph which has been modified. The mortality after an acute event in coronary heart disease, in 1950s there was like 45% mortality within the first year, and nowadays it's in single digit. So this decline in mortality over the last 60 years, 70 years now, has been very smooth like an airplane landing. There's no sudden jump, no sudden drop. If that's because of the various modalities of treatment, drugs, the trials have made a difference. So sometimes we wonder if we are doing the right thing. But when you look at an insurance figure graph of the mortality of people, you think that we are actually going the right way. And that, despite the fact that we made progress, there's a big debate we have with surgeons, which sometimes can become quite aggressive. And it can really become very enthusiastic. And the big effect in sometimes we see a lot of in this part of the world is that the patient becomes totally confused. The surgeon is going to say, I'm going to operate, and he will say that the angioplasty will not last. And we will say, why do you want to mutilate yourself? So the patient becomes really confused and comes to you many times not knowing what to do. So we need to find this way of avoiding the conflict of interest, if you may. We need to take this concept from one of our fellow other species on this earth. This is a story of two donkeys who want to eat hay, and they were tied together like we and the cardiac surgeons. So they tried harder and they could not eat. So then they had a cath conference and they decided that we should go eat one stack first and then go to the other and eat the other stack first. And that is a good way of doing it. But the thing is that with a surgeon, the trick is when you're eating together is to eat faster. So whereas the surgeon can do 3 or 4 cases, we can do 8, 10 cases. So you eat faster and you can still compete with them quite well. The reason the surgeons say that we are temporary is because the first presentation which a cardiac surgeon gave about angioplasty after Andrew Grunze gave his presentation was it's like a moth which is going to come out and get caught, and it's just a year or two and they'll be gone. And they never took us serious since then. But we know that it is the best time to be in intervention right now. The failure rate, the emergency CABG, the restenosis, thrombus, the VLAS, they're all really way down because of various procedures, developments which have happened, including imaging, IVUS, OCT, and the stent modification, new stents, devices, and the use of intravascular ultrasound had really shown some improved outcome, which a lot of us try not to do for cost issue, but you cannot agree with this, but still the facts are fact. There is a difference in stent also. And the drugs which are applied to stents probably make a big difference too. And as is shown here, that everolimus is superior to sirolimus. And the other is the technique of deployment. We kept on reading that, two-stent strategy was a bad idea. And then it realized that if it is a significant vessel, a significant disease, then two-stent strategy becomes better. And we never really bothered about the type of technique till the data started coming out. And we showed that Culot is better than crush, and that DK crush is better than any other procedure. And the DK crush, I think, is improving. One of the reasons why this is so is, my concept is that we finalize this technique so much, the distal crossings and the pot and the dot and so on and so forth, that the stents are so well deployed. It's like we're seeing in the TAVR business that initially when the TAVR came out, people didn't know what actually they were doing. They didn't even know how to size it well. So now they've learned from the procedure, they've learned from technique. So my feeling is that if we do a proper Culot and those things, the result would probably be very comparable. And that has not been the only development that's happened. The new drugs, the clopidogrel, the prasugrel, the ticagrelor, they've all made a difference and improved the outcome. And the way their efficacy works, their bleeding tendency also changes. So by looking at this, we can say we can down escalate the antiplatelet, up escalate depending on the patient, whether he's bleeding risk or he's at a thrombotic risk. This slide is something very important, and now we know how to deal with a high bleeding risk patient. So somebody's on triple therapy, he has PCI, maybe 7 days or a month of triple therapy, and then you're down to 2 therapy, and after a year, you just stay on the NOACs. It'll cover you for both the dual antiplatelets and the NOACs. With all this progress, the length of stents kept on growing. And in the Syntex, the average length was 86 millimeter, and some patients over 300 millimeter stents are used. And in the trials which followed for CABG versus PCI, the MACE rate kept on coming down. From the POBA to bare metal to drug looting, and now the Excel and all, they've got wonderful outcomes. So, when we talk about CABG versus PCI, invariably when you talk about left main stem, it always ends with the debate on PCI versus CABG. So we're equally good stakeholders now, and the question is not which is better, but which is better suited for that particular patient. So we need to tailor the management according to patient. And with the data I'm going to present you later, there's strong evidence that PCI is a reasonable alternative in selected left main stem cases, and the threshold for performing PCI as left main has become lower and lower. And there's a rapid rise in volume. That's the market for you. And the surgery is shrinking. And there is a concern that we are probably overusing or misusing or inappropriately using PCI for left main stem. That remains to be seen. But the drive for this is basically a lot to do with the cultures also, especially in Asian culture, where religious, socio-economic factors and lack of social welfare support, they all drive a person towards PCI. So when we decide for any angioplasty, any procedure, if the lesion is complex, the comorbids are low, the patient has a bypass. And this is like a 2007 slide of student PCR, and I've seen that this formula does not change. It has not changed over time. So if the lesion is simple, there are more comorbids, you tend to go for PCI. And in between, you can shuffle around, and you need a heart team to help you decide. So we work out the complexity of a case with the syntax. We work out a global risk score, the STS operative risk calculator, and then we put that to the heart team. And if patient has comorbids, other people join the heart team and they help us decide which way to go. But the bottom line is that whichever we go, patient do not want to have surgery. It is why would somebody want to have his tooth pulled out? Of course, they can put in a transplant and a tooth there, but why take it out if you can save the old one? We talk about the guideline. The guideline is that for left main stem, am I short of time? Okay. So for left main stem, a single vessel, everything with LED involvement is 1A for surgery. And for PCI, if it's shaft, ostial, it's 1A. If it's with a single vessel, it's 1B. And if it's 3 vessel with left main, it's a contraindication to 2B or 3. Which is a contraindication. The guidelines from European side, and then they're from the AHA, and the AHA tends to be more stricter, whereas the Europeans just apply the syntax score and give recommendation for PCI. The American Heart Association talks about the ostial shaft and distal bifurcation, and that's how they suggest how to do a PCI. And when we think that we've worked out everything, something new comes up. Like the Excel, when the core lab looked at the stratification, initial induction was for less than 32 score syntax, but a quarter of people in Excel had more than 33 score, so they were high risk. So the result you saw in Excel was actually dealing with a very complex group of cases. And so there is now provisional and two-step strategy, and there are good algorithms of how to choose between them, which involves using the IVUS and FFR. There are favorable characteristics for surgery, the diabetes being the topmost, reduced LV function is another. And there's been some controversy that diabetes do not go well with angioplasty, but then diabetes doesn't go well with surgery also. So the best people are those who do not have diabetes. Then there's a meta-analysis in JAC 2022 that by and large CABG remains on the right side of the line of continuity. However, the left main trial of main compare showed that there was no difference over 10-year period between PCI and surgery in left main stem. So the choice between PCI CABG is a debate, because this debate is such because of the heterogeneity of the disease process and the patient, and lack of uniformity of the end point across various trials and the different techniques which we use in PCI. And so the goalposts keep changing. Whenever you think you're in the right track, something changes, new data comes up, and your thought changes. So what's so special about the left main stem? It is not a difficult vessel to treat, but because it supplies such a huge area, the vessels are big, different angulations, you cannot choose which is the main branch sometime, which is side branch. In ACS, there's a lot of thrombus, calcification, low EF. You need to treat more aggressively, and you need to do imaging and devices and other technical aspects, which route to take, radial or femoral, 6, 7, 8 French, side branch, OCT, FR, pot, dot, all the things make up the complexity of the disease, whether you use an impella or for us or an intrathecal balloon pump. Now they all add to the diversity and complexity of how people would do PCI. So these are some of the we talked about trials, these 5, and they've been basically used in the guidelines. There's a 5-year outcome which suggested that the story remains the same. Cabbage versus PCI, there's a higher rate of instant restenosis. The end mortality remains the same, and that, believe it or not, has been going on right from Barry till now. There's high PCI ISR, and there's fatality remains the same. And there's another meta-analysis showing no mortality difference between PCI and cabbage. Same old story, but higher ISR. So you offer them a 1 in 20 chance of having another second procedure, but mortality remains the same. So Excel Nobel, a bit of that, and then initially the Excel did good well for 3 years, but in longer follow-up there was a crossover. Surgery became better. They're quite debatable. So there's a difference in stroke, death, MI, and ISR in 3 and 5 years. This is the data analysis of the Excel, which again matched the syntax score. But the interesting thing was, so whenever we seem to come to a blind end for any procedure, something else comes up. So now we have come with this very ultimate trial suggesting that when you use an IVUS, the outcome of PCI for intervention in a left main becomes totally different, and there's a significant improvement. So now we've got a new, it's not a new toy, but we need to reintroduce it into our procedures. And the 10-year follow-up, the syntax showed that although there's this big difference in the outcome in high syntax score, but in left main, the outcome was very comparable, and that's where it shows that for left main, the 10-year follow-up versus surgery was comparable, unlike the 3-vessel disease where surgery is more beneficial. So how do you talk to your patient? What do you tell them? You have to be intellectually honest, and you should not have any conflict of interest. And we need to think of the patient, and there's no room for ego. We like to do big procedures, and like we sometimes do a procedure and I say, look, we're not doing this for the masters, we're doing this for the patient. That's very important, that you don't do something to show it off later in a conference. So is it a technically good idea? So I talk to them, it's not just the destiny, it's the journey also. So for the next 3 to 5 years, you're going to have a good time, and you might need a second procedure, but by and large, every coronary artery disease, PCI or surgery you do, in 5 to 10 years, you would need to do something else about it. It's a progressive disease. There's not like a bloody flu which comes and goes. This is like a dimmock. It's going to stay with you, and you're going to keep on dealing with it. And so they're going to peri procedural events up to 3 to 5 years. It's an easier journey. There's no different mortality, and you expect a 1 in 20 repeat procedure. So the heterogeneity, which is there in the definition, we're in the conclusion, sir. Definition, composite endpoint, co-confounders, and makes it improved to draw a definite conclusion. Treatment of left main stem be considered as an alternative strategy on basis of patient's characteristics and anatomic consideration, clinical presentations, and patient preference. And so there is no evidence to there's now sufficient evidence to suggest equipoise regarding death, stroke, MI between PCI and cabbage and left main stem. And there's increased MI, which is countered by increased chance of revascularization in PCI versus surgery. But the real world, we are continuing to debate, whereas in real world, the PCI continues to grow and surgery keeps on dropping. So the medical community seems to have made its choice. And we are now calling for more data, but I think despite this, we can continue to have data. We have sufficient to work on what you're doing right now. It is time to move on, focus on more improved medical treatment, control diabetes, and preventive methods, improving stent technology and optimizing PCI techniques, and leave the decision of PCI versus cabbage to the heart team and share decision based on, more importantly, the local environment, the local expertise, and not just international published data. Thank you very much.